Hi friends, so a lot of questions are also asked on neuroimaging in your particular exam. So let us deal with a few important topics as far as CNS imaging is concerned. So look at this recently asked Ini-Cet pattern question. So a young male was with a history of road traffic accident was brought to the emergency room. He was showing altered sensorium. Look at the GCS. He had no fractures, no hydrocephalus, right, with raised ICT, a little bit of raised ICT. So non-contrast CT was performed, right, and was found to be normal. So see, this is actually a history clincher. A history of trauma with altered sensorium with a normal early CT scan is what? So this, in fact, friends, is a history clincher. What is this history clincher? So an altered or non-improving altered sensorium, right, in a head injury patient with normal early CT scan brain. This is a history clincher for what? This is a history clincher for diffuse axonal injury, right? So this is a history clincher for diffuse axonal injury. What is that? Altered or non-improving altered sensorium in a head injury patient with normal early CT scan brain. Now remember, as far as head trauma is concerned, so for all conditions related to head trauma, usually the investigation of choice is going to be a non-contrast CT, right, because CT can be very quickly done. It is able to detect almost all types of bleeds, intracranial injury patterns, but there is one exception to this particular rule. And what is that exception? This exception is diffuse axonal injury. So diffuse axonal injury, and what is that exception? For diffuse axonal injury, the investigation of choice is not CT, it is MRI. Why? Because the answer to this particular question actually depends upon what diffuse axonal injury actually is. So let us quickly have a look. What is diffuse axonal injury? Look at the name. It is nothing but, simply put, it is a type of axonal injury, but this happens in a diffuse manner within the brain parenchyma. So what happens basically is that whenever there is a sudden acceleration or sudden deceleration, right, there are shearing forces or distracting forces which are exerted over the brain parenchyma. The neuron, when a shearing force or distracting force or a twisting force is exerted onto a neuron, the neuron simply breaks off. And where does the neuron break off? The neuron breaks off at its weakest point, that is at the junction of the cell body and the neurofilament. So do you realize simply that this is nothing but a axonal level injury, but this, so an axon is broken, but such multiple axons are broken throughout the brain in a diffuse manner. This is what is called as diffuse axonal injury. Naturally the patient is going to be unconscious, but this break, remember, is a permanent break, right? So the patient is going to show, prolonged periods of altered sensorium. The overall prognosis is usually poor. What happens here is that because this is a cellular level break, early CT scan does not show any imaging findings. What happens with time is that at the site of each of these breaks here, a tiny petechial hemorrhage actually develops. A tiny petechial hemorrhage actually develops. And when a petechial hemorrhage develops, the diagnosis of diffuse axonal injury is actually based upon the detection of this petechial hemorrhage. And MRI, with its specific blood sensitive sequences like gradient echo, susceptibility weighted imaging, has a much more higher sensitivity to detect these tiny petechial hemorrhages within the brain parenchyma than CT scan, and therefore MRI is considered to be the investigation of choice for diffuse axonal injury. Now, in one patient we did a delayed CT, and on this delayed CT we could see some tiny hemorrhages. These are very small petechial hemorrhages, mainly at the gray white matter junctions, suggesting a diagnosis of diffuse axonal injury. Now, as I said, MRI is the investigation of choice. What sequences are used in MRI? Blood sensitive sequences like gradient echo sequence or susceptibility weighted imaging, right? These are blood sensitive sequences in which blood appears as blooming, that is black spots. So blooming means black spots. So blood accumulates or blood appears as blooming or black spots within the brain parenchyma. Look at this image here. can you see there are multiple, right, black spots. If you look at the site of these spots, can you see most of these are located at gray white matter junction. So what is the most common site of bleed? Most common site of bleed is the gray white matter junction. The second most common site is the corpus callosum. The third most common site of blooming or petechial hemorrhages is usually the dorsolateral brainstem. Depending upon where this bleed is, this is also classified as stage 1 diffuse axonal injury, stage 2 diffuse axonal injury, and stage 3 diffuse axonal injury. So this is all you need to know as far as diffuse axonal injury is concerned. So in this particular question, a patient of road traffic accident with altered sensorium, non-contrast CT was normal. What is going to be the answer? The answer here is diffuse axonal injury. Now let us quickly look at a few more potential questions that you could be asked as far as head trauma is concerned. Right, so if you look at a history of trauma and you're looking at a CT scan, when you see a bleed, see bleed appears hyperdense like this, all you need to see is whether there is a rim of edema around that bleed. If you see a hypodense or dark appearing rim of edema around it, look here, every bleed here has a hypodense rim of edema around it. If you see a rim of edema, remember that this bleed is where it is inside the brain, and therefore the diagnosis becomes hemorrhagic contusion of the brain parenchyma. Hemorrhagic contusion of the brain parenchyma. Okay, so this is what is hemorrhagic contusion. History of trauma, bleed inside the brain that is confirmed by the rim of edema around it. This is called hemorrhagic contusion. This is not diffuse axonal injury because in diffuse axonal injury the size of bleed is very small. Remember we discussed it is just a petechial hemorrhage, right? This is not a petechial hemorrhage, this is gross hemorrhage. Traumatic hemorrhage within the brain is what it is, hemorrhagic contusion. Now if you see a bleed, see you see a hyperdense appearing bleed and there is no edema around it, it means that the bleed is outside the brain parenchyma because there is no edema around it. So it is extra-axial. When there is an extra-axial bleed, all you need to look at is the shape of that bleed. Look at the shape of this bleed. This is convex on one side. This is convex on the other side as well. So this is biconvex, right? Extra-axial bleed. What is this? This is nothing but a extradural hemorrhage or EDH. What is the source of hemorrhage in EDH? Remember, it is a middle meningeal artery that is bleeding. This is a middle meningeal artery radical which is bleeding. So that is the source of hemorrhage. Remember that EDH is also associated with a peculiar history, and that is called as what? That is called as lucid interval. So it is associated with lucid interval. Along with that, it is also associated with a clinical phenomenon which is called as talk and die syndrome. What is lucid interval? The patient is unconscious, becomes conscious for a brief duration of time, again becomes unconscious. This brief period of consciousness lying in between two periods of altered sensorium or unconsciousness is called lucid interval. Similarly, talk and die syndrome, immediately after the accident the patient is doing very well, he is walking, talking, performing all his activities, suddenly he collapses and dies because this is an arterial source of bleed. The sudden increase in size is going to compress the brainstem, respiratory centers, cardiovascular centers, patient will suddenly die. So this is what is associated with EDH. Now if you see an extra-axial bleed, why extra-axial or outside the brain? Because if you see around this bleed there is no edema which is there, and if you look at the shape of this bleed, you can see that this bleed is concavo-convex or crescentic like this, then your diagnosis is subdural hemorrhage or SDH. What is the source of bleed in subdural hemorrhage? The source of bleed in subdural hemorrhage is bridging cortical veins. It is bridging cortical veins. Remember, it is a venous source of hemorrhage, and as a result of this, remember, it is a low pressure bleed extravasation which is occurring. SDHs are relatively less symptomatic, right? They are insidious, right? They can go undetected for a very long period of time. You do a CT and suddenly they can be detected. So this is what is about SDH, subdural bleed, bridging cortical veins. They are relatively less symptomatic. Now if you see, if there is a history of trauma and you see a bleed, it is not intra-axial, though it looks inside. It is not inside. Why? Because there is no edema around this bleed, but the shape is linear. Can you see this line, bright hyperdense line there? Shape is linear. Why? Because this bleed is where? It is within the sulcal space, and bleed within the sulcal space is called as what? It is called subarachnoid hemorrhage. So bleed within the sulcal space or within the basal cisterns is called as subarachnoid hemorrhage. So this is what is SAH. Yes, so this is bilateral acute SAH. Yes. Now, if there is head injury and there is involvement of the skull base, especially the anterior cranial fossa, what is going to happen is that there are paranasal sinuses here, especially the frontal sinus. If there is a fracture involving the one of the walls of the frontal sinus, what is going to happen? The air within the frontal sinus is going to go into the subdural space. This is what is called as pneumocephalus. Pneumo means air. So cephalus means air is within the cranial cavity. If there is a large amount of air within the cranial cavity, then the pressure of this air within the subdural space becomes very high, and because of this high pressure, it is going to compress the underlying brain parenchyma. So this brain parenchyma is going to get a pointed appearance like this. This is what is called as the Mount Fuji sign. Mount Fuji sign is seen in not just plain pneumocephalus, remember, but it is in tension pneumocephalus. And because there is tension pneumocephalus, that is, this subdural air is at a very high pressure, it is compressing the brain. This will need emergency management in the form of drainage of this particular air, so that this high pressure compression on the brain parenchyma can be relieved. So this is what is the Mount Fuji sign in tension pneumocephalus. Now look at this. This is a history clincher. This is not a case of head injury or trauma, remember, but look what is the classical history here. A middle-aged patient presents with thunderclap headache, right? And this is a clincher and altered sensorium. So once you read this word thunderclap headache, this is also sometimes called as the worst headache of life. So worst headache of life or thunderclap headache. This is what is suggestive of what? This suggests aneurysmal, yes, so aneurysmal subarachnoid hemorrhage. So this is aneurysmal subarachnoid hemorrhage. Aneurysm means the source of subarachnoid hemorrhage is rupture of a berry aneurysm. And where are berry aneurysms located? They are located along the branching points of the circle of Willis. What is the most common site of a berry aneurysm? It is the anterior communicating artery, right, between the two anterior cerebral arteries. Because the circle of Willis is located in the basal cisterns at the base of the brain, if an aneurysm here ruptures, the first place that the blood would accumulate would be within the basal cisterns. So here if you see, at the base of the brain, all these basal cisterns are completely full of acute blood. So it is appearing hyperdense. Normally they are filled with CSF, so they should appear hypodense. Here they are appearing hyperdense because they are filled up with acute blood. So this is what suggests aneurysmal subarachnoid hemorrhage. Very poor prognosis. Hunt-Hess scale is used clinically to assess this, right? Why very poor prognosis? Because this SAH is going to irritate the circle of Willis arteries. They are going to go into vasospasm, and that would lead to secondary ischemia of the brain parenchyma to which they are supplying blood. So this is what is the typical history clincher of aneurysmal SAH. Yes, so this is aneurysmal SAH. Now we come to ischemic stroke. Remember, patient presents with hemiplegia, hemiparesis. Remember the earliest modality. So the earliest modality to diagnose an acute ischemic infarct, if your examiner specifically asks you this question, what is that question? Earliest modality to detect an ischemic infarct, then it is going to be diffusion weighted imaging MRI. Remember, right? Diffusion weighted imaging MRI can detect an acute ischemic infarct within the brain parenchyma as early as 30 minutes from onset. This appearance on diffusion weighted MRI is called restricted diffusion, where you see an area on DWI, right, that is appearing bright or hyper intense, and a digitally generated image, that is an ADC map or apparent diffusion coefficient match or map. The same area is appearing slightly hypo intense or dark. An area that appears bright on DWI but dark on ADC suggests restricted diffusion at your level. Remember, with a clinical history of stroke, that is hemiplegia, hemiparesis, it suggests acute ischemic infarct. Earliest can be detected by diffusion weighted imaging. If they ask you what is the best investigation to be done in acute stroke, first investigation in acute stroke, it is not DWI MRI, because MRI takes a lot of time. Therefore, the investigation of choice in acute stroke is usually CT. The purpose of doing CT is not to detect an infarct but to rule out a hemorrhage Once hemorrhage is ruled out, what remains is infarct. You can treat it empirically by using thrombolytic therapy. Only when the examiner specifically asks you earliest modality to detect an infarct, only then the answer is going to be diffusion weighted MRI. Remember? So on CT is going to be the first or the best investigation in acute stroke. This is how a classic acute ischemic infarct looks like. Look at this hypodense area. It is triangular in shape, so a wedge shaped area, because this is the arterial distribution territory of the middle cerebral artery, which is wedge shaped, and therefore it is appearing wedge shaped. It is diffusely hypodense. Why? Dark. Why? Because the affected brain parenchyma is edematous. It is involving gray and white matter because both of them are supplied by the same artery. Therefore, there is loss of distinction between them, and because the brain parenchyma is edematous, there is a lot of mass effect. It is showing midline shift to the left side, the compression of the ipsilateral lateral ventricle, right? These are all evidences of mass effect. So this is a classic appearance of an acute ischemic right middle cerebral artery territory infarct. Okay, this is a classic appearance. Now sometimes, see, look at this clinical profile, right? A 42-year-old male presents with left hemiparesis without any cortical signs such as aphasia or agnosia. This is very typical of a type of infarct which is called as lacunar infarcts. So this is lacunar infarcts. What is a lacunar infarct? It looks like a lacuna that is round. It is very similar to an infarct that we saw previously. The only difference is the shape of the infarct. And why is it round like a lacuna? Because it is due to the occlusion of small end perforating arteries like lenticulostriate arteries, thalamo-perforating arteries. And what is the vascular territory of these arteries? It is a small round area which is commonly seen in the basal ganglia. As you can see here, it occurs in the brainstem or centrum semioval, that is the subcortical white matter. So when you see a small round hypodense lesion with a history of stroke without cortical signs, right, pure motor stroke syndromes without cortical signs such as aphasia, agnosia, it is very typical of lacunar infarct. So this is what is a lacunar infarct, classic right-sided thalamic lacunar infarct. Now a patient comes to you with altered sensorium, right, and a high blood pressure. You see a hyper dense bright appearing lesion where within the basal ganglia here. Remember, if you see a bleed within the basal ganglia, it is always hypertensive bleed unless proven otherwise. So bleed within the basal ganglia is always hypertensive bleed unless proven otherwise. Why? Because the most common site of hypertensive bleed is the putamen. Is it within the basal ganglia? Yes. The second most common site of hypertensive bleed is thalamus. Is it within the basal ganglia? Yes. The third most common site of hypertensive bleed is usually the pons. It is not in the basal ganglia, but doesn't matter. Rank 1, 2 and 3, rank 1 and 2 lie within the basal ganglia. So most common site of hypertensive bleed is basal ganglia. Okay. So this is where if you see an acute hemorrhage, it is always right, it is going to be hypertensive bleed. So acute basal ganglia hypertensive bleed, as you can see in the CT here. Now look at this classic history clincher. So a child presents with headache and visual disturbances. A very typical visual disturbance described here is usually a bitemporal hemianopia. And what do you see? You see that this is the sella. The sella is not involved. Above the sella, that is the suprasellar region, you can see a cystic lesion which is showing a lot of calcifications in a child. So a cystic lesion with a lot of calcifications in a child suggests craniopharyngioma. This is a clincher of a lesion. Remember, child presents with a solid cystic calcified lesion in the suprasellar region. As you can see here, see there is a cystic component. These bright dots that you see here are calcific components here. So this is very typical of a craniopharyngioma. Similarly, if you see a lesion in the cerebellopontine angle, so this is pons, this is cerebellum, this is the cerebellopontine angle. In the cerebellopontine angle, you see a big chunk of ice cream and a narrow cone on which it is sitting. So this is what is called as the classic ice cream on cone appearance, and this is what suggests an acoustic schwannoma or a vestibular schwannoma. At your level, if you see a particular tumor at a particular site, that site itself should clinch the diagnosis. So in a suprasellar region, in a child, you see a cystic calcified lesion, it is craniopharyngioma. In the cerebellopontine angle, you see an ice cream on the cone appearance, it is going to be acoustic schwannoma. In the cellar and suprasellar region, so look at this tumor, there is a cellar component, there is a suprasellar component. So there is a cellar component, there is a suprasellar component, and this 8-like appearance is called figure of 8 appearance or snowman's appearance. This is suggestive of a pituitary macroadenoma. Macroadenoma because macro means more than 10 millimeters in size. Microadenomas are usually less than 10 mm in size. So you see a snowman-like lesion, 8-shaped lesion, the number 8, digit 8-shaped lesion in the cellar suprasellar region in an adult. So this is the most common lesion of the cellar suprasellar region in an adult. In a child it was craniopharyngioma, in an adult it is pituitary macroadenoma. Right now in the posterior fossa, especially in children, if you see a lesion that predominantly arises from the floor of the fourth ventricle, it is usually an ependymoma. Whereas in children, if you see a lesion that predominantly arises from the roof of the fourth ventricle, then it is usually medulloblastoma. Posterior fossa lesions, floor, ependymoma, roof origin is medulloblastoma. Meningioma is a very prototype extraaxial lesion, right? It is the most common primary non-glial tumor. Some clues to diagnose meningioma: remember, these tumors usually have a broad base towards the dura because that is where they are arising from, and towards the edge of that particular lesion they are showing a tiny tail-like projection like this. Can you see this tiny tail-like projection? These blue arrows here, right, that is pointing to, these are what are called as the dural tails. So a broad base towards the dura and tiny dural tails is very typical of a meningioma, right? This meningioma is associated with an elevated alanine peak on MR spectroscopy, on angiography. It is supplied by both the external and internal carotid artery. There is a mother-in-law sign which is just been described on angiography. That is because the contrast is retained within the meningioma for a very long duration of time. So this is about few important tumors. Well friends, we have had a very brief, right, very rapid, concise, high yield revision of various neuroimaging spotters that you could be asked in this exam. Remember, a little progress each day adds up to big results, and all this preparation, all this extra effort that we are putting in is to ensure that you get that big result in this upcoming exam. Keep studying till the very last moment, believe in yourself and give your best shot.